I really do believe that what ocular oncology looks like at the beginning of my career is going to be a world different than what it's going to look like at the end of my career.
Welcome to EyeCan, a podcast about ophthalmology through a uniquely Canadian lens with Hady Saheb and myself, Heather O'Donnell. Season 5 of the EyeCan podcast is brought to you by Bayer Ophthalmology. We thank them for their support.
La saison 5 du balado EyeCan vous est offerte par Bayer. Nous les remercions pour leur soutien. We will be sharing our experiences as ophthalmologists today and tackle some of the challenges we face as healthcare providers.
Dr. Lauren Dalvin is an ocular oncologist and Associate Professor of Ophthalmology with joint appointments in medical oncology and pediatric and adolescent medicine at Mayo Clinic, Rochester, Minnesota. She has over 175 peer-reviewed publications and was awarded a KL2 grant to support her patient-derived organoid-driven drug discovery efforts for uveal melanoma. She has National Cancer Institute and Department of Defense funding for tree-shrew model radiation retinopathy research.
Dr. Dalvin serves on the editorial board for Investigative Ophthalmology and Visual Science, IOVS, and Canadian Journal of Ophthalmology, CJO, and she is the Associate Medical Editor for the AAO's iNet magazine. She has held leadership positions in the International Society of Ocular Oncology, the American Association of Ophthalmic Oncologists and Pathologists, and the Association for Research in Vision and Ophthalmology. She also serves as an examination content developer for the American Board of Ophthalmology. Dr. Dalvin is passionate about multidisciplinary, team-based eye cancer care and advancing the field through quality clinical and translational research. Dr. Dalvin, thanks for joining us. Welcome to EyeCan. Let's get right into this chat.
Thanks so much for having me. I'm very excited to be here.
So let's start with just the basics. What is uveal melanoma? And tell our listeners how common it is compared with other eye cancers.
It's a great question. Uveal melanoma, much to many of my patients' unfortunate surprise, is actually the most common intraocular primary eye cancer that we see in adults. So overall, the most common intraocular cancer in adults is going to be a metastasis, but the most common thing that comes to us in our practice is uveal melanoma. This is really a rare cancer overall, even though it's a common thing in our practice. About 5 to 6 per million patients will develop a uveal melanoma. I happen to be in an area of the United States where we have a lot of fair-skinned, blue-eyed people who are a little more susceptible to this cancer.
So what are the key risk factors for developing uveal melanoma? You mentioned blue eyes and the location of where the patients live, presumably similar to sun exposure, but are there other factors that are common?
It's somewhat of an enigma. We know fair-skinned, blue-eyed people are more at risk, much like for any other types of melanoma. The sun exposure issue is a very common question I get, and the evidence is very rocky on where sun exposure plays a role. For things that are on the front of the eye, like conjunctival melanoma, iris melanoma, we definitely see a UV signature. But in the back of the eye, choroidal ciliary body melanoma, those have layers in front of them that are really absorbing a lot of UV rays. So things like strong exposures welding potentially increases the risk, but casual sun exposure, it's really hard to say how much of a role that plays. There are certain genetic syndromes that can increase the risk of this, though. One that we've talked about a lot in recent years is the BAP1 tumor predisposition syndrome. So this is something that can be passed down to family members. And although this doesn't count for the majority of uveal melanomas, it's really important to know because patients are going to be at risk for other cancers as well, like skin melanoma, lung mesothelioma, kidney renal cell carcinoma. So when I hear these other things in the family, then I start digging deeper for other causes.
There's lots of patients who come into my comprehensive ophthalmology practice who have sort of larger nevi with perhaps either they're closer to the nerve or they're particularly irregular. Sometimes they have drusen and I'm just following them and I get regular scans to see how high they are and everything's stable and they don't change. So are most of the ones that you see diagnosed because something has changed, or how are they mostly diagnosed? Are they mostly diagnosed when people have symptoms? What are the most common presenting findings?
I'm so glad to hear that you are taking photos of these because that is the number one, best, most important thing that you can do as a comprehensive ophthalmologist seeing these in your practice. Allowing us to be able to go back and really document and see if there's been true change is such a key. A lot of patients nowadays get sent to me because they had a photo taken. And actually, a lot of these ultra wide field fundus photos are helping detect these lesions that probably wouldn't have been seen on an exam until they were quite large. So sometimes a practice has newly gotten one of these cameras, and now every patient is getting a photo with their exam. And all of a sudden, we see this influx of referrals of patients who have nevi or suspicious nevi, or sometimes we even catch a melanoma that way. So most of the patients that I see had a routine eye exam. Maybe they thought they needed an update in their glasses, and maybe they were completely asymptomatic from the tumor. So they're quite surprised to get this finding and get referred to my office. Occasionally, patients do have blurry vision. Those are more often posteriorly located tumors or tumors that have become very large so that they're creating big serous retinal detachments. But a lot of times it's really that photo that makes the diagnosis and gets them referred to someone like me.
Let's take that a little further and imagine a patient who is sent to you and you're convinced that this is melanoma and requires treatment. So what is it looking like now in 2025 regarding standard treatment options for melanoma?
For better or worse, not a ton has changed in several decades. My go-to standard of care treatment, although we've perhaps customized things a little bit more, but is still plaque radiotherapy, which we've been doing since the 80s in the COMS trials. So I offer this, but I also offer other types of radiation now. So we have proton beam irradiation and we have gamma knife radiation. My primary go-tos really are plaque or proton. And we're starting to delve into, now that we have both available in same centers sometimes, which might be better depending on where a patient's tumor is located or how large the tumor is, because they have very different distributions in their radiation fields that might be more advantageous if we're trying to protect vision for tumors in certain locations. They're both really great at killing the cancer in the eye. Unfortunately, we do get a lot of radiation side effects. So we are starting to see clinical trials come along that are really potentially exciting and potentially vision preserving for these patients. So we're seeing things like photodynamic therapy activated nanoparticles injected into the eye to try to treat small melanomas that are potentially in vision threatening locations where we might really not want to have to do radiation. And we're also seeing neoadjuvant systemic therapy trying to shrink really large tumors that otherwise might have had to have the eye removed or might have needed a really large dose of radiation. So for the first time, we're seeing this boon in clinical trials for uveal melanoma. That's really exciting.
No
Amazing.
kidding. Any job where you get to say photodynamic therapy injected nanoparticles, I feel like is like high on the list of like very cool and almost sci-fi.
My vague recollection from my training is that there's often a dilemma about, how aggressive you want to treat the tumor versus how keen you are or how much of a priority it is to preserve vision. Can you share some of those dilemmas and how you navigate balancing control of the tumor and preservation of vision?
This is a very personalized conversation for every patient. So it really depends on tumor location, tumor size, and what are the patient's priorities. So every patient, when I really believe something is a melanoma, my number one priority for them is going to be protecting their life. We know that still, unfortunately, today in 2025, we have very limited treatment options for metastatic melanoma. We know that half of patients are going to end up with metastasis. And the best thing I can do is detect and treat the melanoma when it's small. That's going to mean that they will have a lower long-term metastatic risk. So I always have that conversation with them. And then in the context of at least my expression that life is our number one priority, then we talk about how the patient feels about the vision risks with having to treat a tumor. When I'm dealing with something small, potentially we have a little more flexibility, especially now that we're having clinical trials to try some of these things that might be a bit more vision preserving. When a tumor is large, I really don't want to sit on that any further. And there are some key size factors that I really look at. We know that basal diameter of a tumor, even independent of a biopsy that gives us tumor genetics and tells us metastatic risk, is an independent risk factor of a patient's risk of metastasis someday. And the data have really cut things off at about 12 millimeters. So we know in science and reality, there's no magic shift that suddenly once we're greater than 12, the numbers dramatically change. But we do know there's really good data to show that tumors less than 12 millimeters wide, even with a high risk genetic biopsy result, have a much lower long-term risk of metastasis compared to tumors greater than 12 millimeters wide. So if we're at that threshold, I really want to treat it before we cross that 12 millimeter mark.
Lauren, I heard you allude to this dilemma twice already in our conversation. And so I'd love to unpack that a little bit. The dilemma of if I believe this is uveal melanoma. So here I am, we're chatting with, an expert in uveal melanoma, and you're still referring to a dilemma of whether or not this is a tumor in some cases. So can you share how often is that actually a dilemma for you, somebody who looks at this all the time? And can you maybe share a case or two where this was a dilemma and how you navigated that dilemma?
This is of constant debate in our field. This is one of the only cancers anywhere in the body that we're going to make a diagnosis based on our clinical imaging, that we're not going to make a diagnosis based on a biopsy. That is hard for patients to understand. It's hard for insurance to understand. It's very hard sometimes to explain. But oftentimes, if I really wanted to try to get that definitive diagnosis, I can go in, I can get a tiny amount of tissue, and still a cytopathologist who's really, really, really good can say, can't rule out low-grade melanoma. So it's even at a cytopathological level so hard to distinguish. So then we have small tumors in locations where biopsy is potentially risky for their eyesight. So we are really relying on our clinical expertise and looking at imaging. There is a whole category of small melanocytic lesions that you could probably show to a panel of experts who treat 100 plus of these tumors every year, and we would not necessarily all definitively agree on exactly what to call or how to approach these spots. So in the setting of things that look like high-risk lesions that have subretinal fluid, that look acoustically hollow, that are close to 2 millimeters thick, but maybe a little thinner, I often do have a conversation with a patient where I talk about my experience, my clinical gestalt. In my experience, a spot that looks like this, if we do nothing, has a very high chance of continuing to grow. Right now, it's this size. If we do nothing, we could be in a position where it's threatened your phobia. We could be in a position where we're crossing this 12 millimeter mark and we have increased metastatic risk. We could be in a position where we have to give more radiation. So do we bite the bullet and treat it now, thinking probably this has a high risk of becoming, if it is not already a melanoma? Or do we wait and watch it for 3 or 4 months and see if it's going to grow and then call it melanoma after definitive growth has occurred? It's really a personalized decision with these patients. Again, my bias is always toward protecting a patient's life. So if my experience tells me this is probably going to be a problem if it's not melanoma already, my bias is to get it treated now while it's as small as it can be. But again, some patients really want to preserve their vision and don't want to jump right into a radiation treatment that we know 5 years is potentially going to leave them with a level of potential legal blindness in that eye. So I have had patients say, I understand that there is a risk this could grow. I understand the risk of metastasis. I'd like to watch and wait and see if it grows. I'd like to watch and wait and see if I qualify for a clinical trial in the future. And some of those spots grow and not all of them do, or some of them remain stable for years and then grow at a time much later in the future. I can't predict with 100% accuracy, even with a lot of experience, what every spot is going to do.
That's wild, to be dealing with that dilemma on a regular basis because the stakes are so high. So kudos to you for navigating those tough conversations.
EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we'll try to incorporate them into future episodes.
EyeCan veut savoir ce que vous en pensez. Veuillez envoyer vos commentaires sur le balado d'aujourd'hui ou vos recommandations de sujets à communication@cos-sco.ca et nous essaierons de les intégrer dans les prochains épisodes.
Hassan Rahimi, and I listen to the EyeCan podcast.
So if we can go back to metastasis that we talked about a little bit before, can you talk a little bit more about why this cancer spreads so aggressively and what that means for patient mortality and morbidity?
Every patient who likes to internet search before they come to see me will read this really unfortunate number that half of all patients with uveal melanoma will end up with metastasis someday. This cancer is in a location that has really one of the highest blood flow per unit area in the body. So it is constantly being bathed in blood. And unlike a lot of cancers that we think about spreading via lymph nodes, this really spreads by the blood, which is constantly filtered through the liver. And therefore, when we get metastasis, the liver is going to be the number one site where these things show up. Why are things so aggressive in uveal melanoma? There are many different molecular features about this cancer compared to something like skin melanoma or conjunctival melanoma. Uveal melanoma has completely different molecular drivers. And even though some of the same pathways are upregulated driving these cancers, uveal melanoma doesn't have a lot of mutations that we can target. So it behaves much differently and it's much more difficult to treat. And for whatever reason, it can hide in the bloodstream invisible or with micrometastatic spots in the liver that we can't detect on a scan. And it can show up not only 5, not only 10, but 15 years later sometimes. So I watch these patients for a very long time after I treat these spots.
Thanks so much for that clarification. I'm sure I can imagine it's an extremely difficult job. We had Dr. Matthew Benson on the podcast talking to us about medical genetics a couple of weeks ago, and there were lots of ethical considerations that seem to crop up in his job. And I'm wondering if there's some parallels here, if there are some, especially in cases where the treatment options might be limited, if there are some ethical considerations that you also find yourself struggling with.
It can be tough. So probably thing number one is, do we do a prognostic biopsy in these patients? So I always have a conversation about getting not a blood genetic test for something that we would pass down to family members, but getting a genetic test just of that patient's tumor itself that can tell us if it's a low risk to show up somewhere else in the body someday or if it's a high risk. It's really hard to think about how we deal with those results because right now there's just not a lot that I can do if I get a high-risk test result. It commits us to doing scans more often. Our guidelines say for a patient who's high risk, I should probably check their lungs and liver at least initially about every 3 months, whereas someone who's low risk, I would probably stretch them out a little more quickly toward once a year screening. But it does place a big stress burden on the patients. For patients who are young, for patients who have large tumors, I really strongly encourage this because I do see every now and then cropping up trials for adjuvant medications that we hope might someday decrease the risk. For patients with small tumors, it becomes a much larger dilemma because we do have this good data, as I mentioned, on this 12 millimeter diameter distribution. If we have a small tumor, even with a high-risk biopsy result, their metastatic risk is going to be relatively low. So they're probably going to be knocked out of eligibility from a clinical trial. That prognostic test might not be quite as well calibrated to their small spot. And so then we sort of end up in this situation of really my hands are tied and I don't have anything to offer. And have we created unnecessary stress? And are we doing more scans? So I really have this conversation about what does the patient want? And unfortunately, knowing that we're in a time pressured situation because we want to get the cancer treated and I can't go back and get this biopsy information if we don't do it before we irradiate.
Oh my gosh, that's a tough job. I'm curious, how do you balance your workday? Is the research a break from the stress of your clinical work?
My research really gives me a lot of hope. I think my patients are absolutely what drives me to do what I do in the lab. I would think I would have a really hard time showing up every day and maybe giving bad news and having to talk about metastatic risk. And I do my own systemic screening. So I tell patients when I think there's a metastasis in the liver, I give that news. And then having to do that initial conversation of what we do and don't have available for metastasis right now, I want to change that landscape. And so I think the lab is really what gives me the hope that if I keep doing that, then someday I won't have to have such difficult conversations. Someday I'll be able to say, you know what, this is not the news we wanted, but we have something that we can do about it. And I know it works.
Great segue to talk a little bit more about your research. So, in reading about your work, we saw that you've been developing these patient-derived organoid models. So these are like tiny 3D tumors that are grown from real patient samples to test drug responses. So can you tell us more about how these models work and what your hopes are for how they can advance personalized medicine in uveal melanoma?
Yeah, this is really, the most exciting thing that I do outside of getting to take care of my patients. And I'm so lucky that so many of my patients have donated tissue samples for us to be able to make these organoids in the lab. So they're really cool things. And because I am a surgeon and because I'm seeing these patients, I'm in this very unique position that we can collect these samples and sort of turn them into these little mini 3D tumors quite immediately. So anytime I have a patient who has a very large tumor that needs a nucleation, or I have a patient who has a new metastasis and we have to get a biopsy, we take that sample right away within like 30 minutes of when the eye comes out or when the biopsy sample comes out, and we digest it up into tiny pieces in the lab. And then you get these little teeny tiny pigmented tumors that we put on basically a gelatin-like substance in a dish. And we feed them with sugars and put them in a little incubator to keep them warm. And then they grow up into lots and lots of mini tiny tumors. And what we can do with them is we can actually do really high throughput drug screening. So we can take these tiny dishes, like ice cube trays, but 96 well ice cube trays. And we can put just a little bit of organoids in any of those 96 well dishes, and we can test a lot of different drugs and see what works. And not only can we do that on one patient's tumor, but then we can do that on many different tumors that have completely different genetics. So we could predict what drugs might work best for tumors with different genetics. And ultimately, my dream goal is that once we've used these to propel us into the era of actually having effective drugs, that we can in real time take a patient's liver metastasis biopsy sample, grow it up in the lab, and in a matter of weeks, we can turn it around, having tested a couple of promising drugs, and tell them, this is the one that's going to work for your cancer. This is what you should have.
Wow. On that topic, the recent CJO special issue on personalized medicine and ocular oncology. And so can you tell us more about what's going on with regards to tumor-specific mutations and gene expression and how they're shaping treatment strategies?
Yes, this is so exciting because I really do believe that what ocular oncology looks like at the beginning of my career is going to be a world different than what it's going to look like at the end of my career. We are really taking a good page out of medical oncology's book and starting to look for targetable mutations in a lot of the cancers we treat. So not just uveal melanoma, but other things, conjunctival melanoma, squamous cell carcinoma, basal cell carcinoma. We're able to find things that we can actually get drugs that will specifically turn off the problem caused by a given mutation in a specific patient's tumor and make that tumor stop growing, make it regress. So we can take tumors that previously would have required really aggressive surgeries like exoneration, and now we can give them a medicine that will stop the tumor from growing, cause regression, and if not completely wipe it out, at least make it small enough that we can surgically resect this. And so in my practice, we've been doing a lot of this with things like squamous cell carcinoma. We have a targeted medicine called cemiplimab that's now FDA approved for squamous cell carcinoma. And so you can take these really potentially disfiguring cancers that would have had to be exonerations, and you can just melt them away with these drugs. We can see the same thing for things like ocular surface melanoma or eyelid melanoma. We have BRAF mutations. We now have vemurafenib that we can use to target those things. So this is just really changing the landscape of what we do. And it's also forging much stronger partnerships with our medical oncology colleagues. We really need to work together. We can't work in an isolated vacuum anymore as surgeons. We really need them to prescribe the drug, to monitor for systemic side effects, and then we follow up resecting the rest of the tumor.
On that topic, you had mentioned earlier your interest in multidisciplinary teams for ocular oncology. What's that looking like for you right now? And do you think the members of this team is potentially going to look different in 10 years? But why don't we start with what does your multidisciplinary team look like right now for your uveal melanoma patients?
For my uveal melanoma patients, I have a very wonderful medical oncologist who now heads the Uveal Melanoma program, Eric Dudek. He's awesome. And he is always on the lookout for new clinical trials or for drugs in development for our patients. And so I so appreciate that. And then we also have our radiologists who are reading our scans all the time. It's wonderful that I can pick up the phone and call them and say, hey, does this liver spot look concerning enough that I need to biopsy it? Does it look more like a metastasis or like sarcoid, or is it in a safe location to biopsy? So I'm so thankful that they're always there for me. The melanoma team also has the radiation oncologists, and our team has really expanded because we now have not only plaque, but also proton. So we have the plaque radiation oncologist, the proton radiation oncologist. Proton has a dedicated physicist. Plaque has a dedicated physicist. So they do all of the calculations to precisely target these tumors. So I'm really lucky that I have all those people. And then at the next level, I think we really can't forget all of the people who are right-hand people. I have the most amazing technician who can read my thoughts and who comes from the clinic to the operating room with me, who's a friendly face that my patients recognize. I have the most amazing medical secretary who knows the answers to half of the questions the patients have without even having to ask me. I have an amazing scheduler who gets these patients in because my patients often travel from 6 to 8 hours drive away. It's very common to come see me. And so she makes it feasible for their lives. And then I have a whole team of study coordinators now because we're running 3 clinical trials for patients with uveal melanoma. So I'm sure I'm forgetting somebody, but I really have the most amazing people around me all the time.
That's really extraordinary. The group that you've built, I think when listeners hear what's being done, not just through this podcast, but obviously through other resources, can you help me understand how one individual might start to navigate this like maze of what might be available? Is it clinicaltrials.gov, is it just through websites? Is it only via referral to really skilled practitioners that have these niche skill sets like you, where patients could access care? Because I do think that for every cancer patient, especially ones that have been given more grave prognoses, they're always asking, is there potentially more that could be done? And the question is where to even start.
For uveal melanoma, I think the patient community has done a phenomenal job of really rallying around one another. So there are organizations like a Cure in Sight that will actually partner with us, with medical oncologists, with geneticists, and they put on podcasts and they put on patient educational events and they do fundraiser races. And they really put out good quality information for patients. So it's much better than going and doing a Google search alone because they've really done their fact checking and they really do stay up on the clinical trials and they get those out there to patients. And I really think even beyond that, they provide so much emotional support because it's this group of people who are really going through the same thing. I think you have to be a little cautious because everybody's in a different stage. So some people are in maybe a more stressful place than others. And so you don't want that to drag you down. But I think a lot of the time it really builds people up and gives them a sense of community.
I'm curious about looking ahead. What do you think the next steps are? If you could wave a magic wand, what would be the next question you to answer?
If I could wave a magic wand, I think what I would like to know is I would like to know what's the magic key to preventing and treating uveal melanoma metastasis. I think it's something different than what we've seen in a lot of other cancers where we have these targeted mutations that are really, really exciting. And I think potentially it's in epigenetics, potentially it's in different ways that the immune system functions. But if I could wave a magic wand and know what's the magic key, that's what I would do. But I do think it's happening now. And I do think within 10 years, we're going to have the answer to that question.
It's a really exciting field to be following. Before we let you go, we like to know and learn a little bit about our guests outside of medicine. Can you tell us? We would like to hear a little bit about Dr. Lauren Dalvin. What do you do for fun when you're not doing this amazing research, when you're not doing this incredibly hard work for your patients? Tell us a little bit about yourself, something maybe that our listeners couldn't guess having just heard this podcast.
I love to travel, so I probably do my mental breaks best by getting on a faraway plane overseas to an opposite time zone. And I really love to go good food hunting and probably do too much unnecessary shopping. So if I had another career, I could definitely be a fashion designer. And if you saw my closet, it is full of more things than I ever need, including a shoe wall and dresses arranged by color.
That's fantastic. Now, are you like a foodie when you travel? Do you go and find specific things in the locations that you travel to?
I do. I love food. So oftentimes when I go on a trip, I'll sort of plan out what I'm going to eat each day, and I'll try to make really far advanced reservations. Or some of these places you have to get up early and get your name on a list because you can't do it online, or especially if you're going to a country where you don't speak the language very well. Sometimes it's very hard to make the reservations from the US. But I love to eat, and I always come back 5 to 10 pounds heavier from my vacations.
Oh, good for you. And do you have a favorite around the world if you could make a reservation for tonight? We know if you could wave a wand that you'd say, let's say you've waved the wand, you understand the key to the metastasis of uveal melanoma, and that night you get to celebrate anywhere. Which restaurant are you going to?
Yes, I am gonna have some sushi in Japan. It's my favorite.
Fantastic.
That's amazing. Thank you so much for this chat, Lauren. This was really useful and exciting. And we really appreciate you spending the time and also doing all the great work you're doing in ocular oncology. Thank you.
Thank you so much for joining us.
Thank you so much for having me. It's been so much fun.
Thank you for joining us for this episode. We look forward to bringing you more engaging content over the coming months. EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we'll try to incorporate them into future episodes.
EyeCan veut savoir ce que vous en pensez. Veuillez envoyer vos commentaires sur le balado d'aujourd'hui ou vos recommandations de sujets à communication@cos-sco.ca et nous essaierons de les intégrer dans les prochains épisodes.
Season 5 of the EyeCan podcast is brought to you by Bayer Ophthalmology. We thank them for their support.
La saison 5 du balado EyeCan vous est offerte par Bayer. Nous les remercions pour leur soutien.
Thank you from the Canadian Ophthalmological Society. EyeCan is available wherever you listen to your podcasts and, of course, through the COS Practice Resource Center.
EyeCan est disponible partout où vous écoutez vos balados et bien sûr au Centre de ressources pour la pratique de la SCO.
EyeCan is written and directed by Kim Tytler and produced by John Allaire from Allaire Strategic Works.
EyeCan est écrit et réalisé par Kim Tytler et produit par John Allaire d'Allaire Strategic Works. Some episodes this season will include relevant links and show notes, so be sure to check episode descriptions to learn more. Certains épisodes de cette saison incluront des liens pertinents dans les notes d'émission, alors n'oubliez pas de consulter les descriptions des épisodes pour en savoir plus.
If any of our listeners have topic ideas to submit, please email them to communications@cos-sco.ca, and we will review for consideration.